Hello, everyone. Good morning. My name is Dr. Samantha Landau. I'm an attending at NYCPM. When I was first hired, I did a year-long fellowship with the intention of replacing Dr. Cusack and/or Dr. Osek in some capacity. Dr. Cusack was the director of the Gait lab, but he's since retired in June, and so I guess I'm now the director of the Gait lab, and this is what I do every Thursday. Patients come, whether they're in the process of getting a custom foot orthoses, and we walk them. So today, we're going to talk about one patient in particular, but what you're capable of doing with this device. How many of you do computer-assisted gait analysis in your office? A show of hands. Does anyone have anything? A few? Okay. I have nothing to disclose. So the objectives today, we're going to go over some data from this particular patient and some articles on the offloading technique depending on what kind of amputation was performed, the mechanics and pathomechanics related to the amputated limb and the contralateral limb, and discussing the CAGA, computer-assisted gait analysis for short, on both sides. So something that, I started to think about more, and when Dr. Jacobs said that, I love that. You really do have to watch every person walk, and I'm always so surprised when podiatrists don't. They just come in, see the patient, assess the foot, and they don't watch them walk, and you're missing so much, actually. I really watch maybe too many people walk now, where I don't like going to places where a lot of people are walking. But, let's say you're on call and someone has gas gangrene, maybe this is something you should be thinking about now. Obviously, you're not going to have them walk, right? But if they need an amputation, you should start to think about, you want to clear out the infection, but whatever's left, the tendons that you have to cut away and the bones that you have to cut away, it all has implications. So, for example, Dr. Daryl Phillips, who's a really amazing expert also in biomechanics, and I've learned so much from him, he told me about an article that I wasn't aware of when I was a resident, that when you have a hallux amputation and you lose the long flexor tendon, there's an anatomy paper that shows that there's a slip to the second long flexor tendon. So that destabilizes the second MPJ, and that's why you get a hammer toe almost always every time you have a hallux amputation. So that's just affecting it in one way. So the stance phase and swing phase. So what do you think is going to happen if you have a hallux amputation or a transmetatarsal amputation, for example? Right, so obviously you're not going to have pre-swing because that's toe off. That's going to be shortened. That's an obvious answer. But it's really similar to what happens in geriatric gait. You're going to have, you're not going to move faster. You're going to move slower, right? And that side is going to be shorter. So right here, the lever arm is going to be reduced. What do you think that does to the affected side? Do you think it requires more force on that hip and knee joint? I think so, but they have to have the power, right? The patient has to have the power of their hip and knee to utilize it more, or it's going to sort of resemble a steppage-like gait. They have to increase the motion at their hip and knee joint on that side, and the step length is reduced. So if the other limb now has to have a longer time, what do you think that's going to do? It's going to torque the superstructure on that side and the foot that's planted at that time, and the timing's going to be off. I love this one. So mainly because if you read the text on the bottom, so this is a peak dorsiflexion and the level of amputation, NC is the normal. But the bottom line here, I was like, oh my gosh, it sounds like Dr. D'Amico. The consequence of this delay is a slowed forward progression of the body center of mass and transition to the subsequent period of double limb support. So you're moving much slower with each amputation, and the more proximal that you go. Right? Doesn't it sound like you? I was like, he's not the author, though. So that's going to torque the planted limb. So you could see where I'm going with this, right? Orthotics. So the level of amputation also, very similar to, luckily stiletto heels aren't really much in style right now. It's the chunky heels, but the less of the foot that you have, the more ground reaction force and peak pressure you're going to have. It's an inverse relationship. So if that confuses you, because I see some students here, just like with a stiletto heel, right? You're probably going to get a little bit more pain because it's less surface area contact as opposed to a thicker, chunkier heel. And it's the same thing with the foot. So if you have more surface contact area, it's going to be less ground reaction forces and less pressure. So the level of the amputation, the area immediately proximal to it, is probably going to have a lot more pressure. So for those of you who answered in your head on the questions that I just asked before, it is going to increase the quad activity if they have it. It's going to put more demand on the amputated side superstructure, demand through those joints, and then it's going to torque the planted limb side that's acting longer now. So what do we typically do for that? So depending on the level, it could be toe fillers, it could be custom foot orthotics, right? They have to heal first, but this is stuff that you should start to think about when you do have gas gangrene or you do have osteomyelitis and you're gonna have to do the amputation on them. You know, you can't guarantee to what level or what's gonna happen, but in the timeline of what their treatment plan is, I think it's a good idea to be like, and suggest and talk about what could develop in the future. So this slide just has to do with the peak pressure and the inverse relationship, similar to the stiletto heel example that I gave. So in this paper here, it's they compared TMAs of diabetics with an age-matched control, and they did find they had decreased range of motion and power at the ankle. They had earlier onset of hip flexor moment, which I suggested before, and they had shorter step length and slower walking speed. So they're moving a lot slower, and it's really mimicking like a geriatric gait pattern, but with asymmetries as well. And in this paper, they had said, based on the previous gait study that they did, they believe that patients with diabetes and/or peripheral neuropathy, they didn't believe that they were able to compensate for all of these issues by increasing the power at the hip and knee, because most of them weren't even capable of it. So what could happen then? Then they can really be dragging that limb and or re-ulcerating. So Dr. D'Amico just touched on this a little bit. CAGA, or computer-assisted gait analysis for short. I really like the one that we use at the school. We use an in-shoe pressure system like this, where the sensor goes into the shoe. I really, really like this one, and I've seen the other ones. When I spent time at HSS, they use one where the tile has the sensors in it, and even though there is useful data in that, it's very similar to a mat, just much more expensive, but you have to, you know, for the patient, has to land a specific way on that tile. The whole foot has to be in it, whereas this one, the sensor gets trimmed down and placed into the shoe. You could even do it barefoot if you wanted, if you had nylon stockings, but this really tells us a lot of valuable information. And why I'm comparing it to the other one, because of those requirements that you have to land a certain way and the patient ends up altering their gait, I don't think it's a very good representation of what's actually going on. So this example here is from an article about computer-assisted gait analysis. This isn't mine, but you can see what the patient looks like without an orthotic and with an orthotic on the left. So it's not just, you know, looking at red, it's also looking at the center of force line, the increased surface area contact. So that's something you guys should take note of too. Similar to like the stiletto heel, the more surface area contact the foot has, the better it's going to perform. And you don't want this line to be going too far in. You want it to be somewhere middle and representative of what the body weight is doing during the gait cycle. But you can see left compared to left, right compared to right, it did improve with the use of the orthoses. So this foot right here is mine. With help of Dr. D'Amico casting me, I've been neutralizing my own deformities, and I've been walking myself barefoot every so often, seeing how I've improved myself. But you can see here, still barefoot, I do need an orthotic. Why? Because my center of force line goes in too far medial. I'm not using my first MPJ as I should. And when I looked at my numbers, my timing was off. This was just barefoot alone. So just like Dr. D'Amico always says, barefoot walking is only good in the jungle. So this patient that I'm going to talk about today, he's an interesting guy. So he's a 50-year-old male that was referred to me. You'll notice that some of his digits are gone, right? But he has digit 4 and 5. He's diabetic, but if you ask him what he does for work, he would say that he's an entrepreneur. And that has to do with what happened to him. So I think it was during a snowstorm. He was selling illicit substances and didn't want to go back inside because he said he was making too much money. And he ended up getting frostbite. So once he healed, he was sent to me. Initially, he was in a cam boot walker until the distal stumps fully closed. And, you know, he's not that compliant. I think he was even supposed to see me this week and didn't come back in. But my goal was to offload him because his pain was on the right foot, as you can imagine, submet 1-2 area. He felt that it was burning and, you know, there's no ulceration, but he had some discomfort there. So he always likes to match his clothes to his shoes, so he doesn't always take my advice for shoe gear. He likes to look very nice, and he usually does. So this is his radiograph for the students. It's not transmetatarsal amputation, like they always say. It's hallux second and third digital disarticulations at the MPJ. So the metatarsal heads are still intact, and that's why he does have a lot of peak pressures there, because mechanically he's still trying to toe off. And this is the lateral on the left, and I also have radiographs on the right. So whether his right limb was longer initially or not, it's now displaying aspects just from the radiograph that is the longer limb. His AP Meres is going medially. He now has a bunion forming on that side with hallux interphalangeus. The forefoot's abducted. This right first MPJ, first ray, is not bearing the appropriate amount of weight. How do I know that? His cortical thickenings of metatarsals 2, 3, 4. So you can tell a lot from the x-ray, right? And then on the lateral, you see it too. There's some anterior lipping of the ankle joint, some midfoot sagging, and he has a hammer toe developing on the second, likely from the hallux valgus on the first. So ideally, when someone has digital amputations, right, well, that's why a cam boot walker works so well for this, because it's really Perry's triple rocker, right? It has a rear foot rocker, a forefoot rocker, and it evenly takes away the increased pressure in the forefoot. In fact, if any of you have had a plantar plate rupture ever or injured any of your MPJs, that's why a surgical shoe doesn't feel as comfortable as a cam boot on that side, because a surgical shoe will only reduce forefoot pressure about 25%, but a cam boot will reduce it at least 75%. According to the studies. So this is just his foot in his Puma sneaker alone. So it had a 0 heel drop, which means the difference between the heel and the toe was the same. Ideally for him, that's not what I wanted. And the forefoot had no rocker at all. So what do you think that would do to someone who needs a forefoot rocker? If you place them in a sneaker that has no forefoot rocker and 0-degree inclination, along with a 0-degree heel drop, that actually puts even more demand on the forefoot and increases the risks of pre-ulcerative lesions. So, and this is his 3D recreation. So you can see here along the first MPJ area, first, second, third, where he had proximal to his amputations, he is having increased pressure there. but he's a little difficult sometimes, and he refuses to change his shoes. But we still helped him. So this is why the shoe alone is really bad. You can see here that he has a lot of, on the waveforms on his left side where the amputation is, the peak pressure is too much on that left, and it has to be reduced. So the lab that I used, I don't know why they did this, but I had ordered a toe filler along with my custom foot orthoses when I casted him, and they sent a separate toe filler with just an inlay and my custom foot orthoses separately. So this study here, this test, was just his custom foot orthoses without the toe filler. But you can see that it actually adequately and greatly reduced the peak pressures on his left foot. And in addition to that, it neutralized, in my cast and prescription, his proximal deformities that were adding and putting more stress on that area and more demand. So I couldn't change his shoe gear type, to increase a 4-foot rocker, but this was successful. And his right foot performed better too compared to just the shoe alone. And you can see here everything was neutralized. This is a nice sea of blue, especially on the right as well compared to the shoe. So these had the best numbers for him, and that's the goal. In terms of heal time, it's sort of hard when you have an amputation to get it 1-for-1, but he definitely performed the best. So just for fun, I walked him with the toe filler as well. And what they gave me for the right side, just so you guys know, it was just like a triple layer dual density plastizote. So you can see this, it was better than the shoe, but it's much worse than a custom foot orthoses that was designed to neutralize all of his deforming forces. Even though this is plastizote and it's supposed to, conform to his pressure, his peak pressure areas, he's still having peak pressure there. So it's because in part, the proximal deformities were not neutralized. So that stress is still there. And you can see that here. So with a toe filler alone, it's not adequate enough. So he definitely needed more. But what the toe filler did do that, ideally I would have wanted to incorporate both, is that it did increase it made the left limb appear longer than it did, and it made the timing of both of his limbs more symmetrical, which is also a goal. So his heel symmetry and limb length symmetry was the best with the toe filler, but the custom foot orthoses was the best overall because it reduced the left forefoot pressure the greatest. So this is, there's not actually too many articles on just toe amputations alone, in regards to mechanics, but this paper out of Egypt, it's not saying anything crazy, but they found that the peak pressure were significantly increased under the first MET following a hallux or big toe amputation, right? That's not like anything crazy. It's like florals for spring. Everyone knows that, but they actually said it, and they have numerical data to back it up, which is always important. And they compared that to the contralateral foot. So improvements. For that patient, I really would have wanted him to have a 4-foot rocker, and that's why the cam boot works as well. The cam boot for him would have decreased all the 4-foot pressure basically. But what are issues with cam boots? What do you think, aside from it being heavy? They're usually 1.5 inches to almost 2 inches longer than the contralateral limb. And this could apply to even if you guys prescribe patients with Achilles tendonitis or anything like that. Anytime you use a cam boot, that limb is going to be much longer than the contralateral limb. So what do you have to do? If a patient walks for several weeks, I would say even more than 10 days, without a leveler on the contralateral limb, that's going to increase lumbosacral, hip, knee, and ankle pain on both sides, but especially the limb that is now acting like the shorter side. So what I did too, I wanted to mimic this. I wanted to actually see what the effects of a cam boot were. So this is me, my left foot with my orthotic. That's why it looks like such a pretty sea of blue on the left. And the right is a cam boot. So the cam boot, like, greatly and significantly decreased all my forefoot pressure on the right side. There's no orthotic in it, it's just the cam boot alone, but this is why it's so important as well that for any reason that you're putting a patient in a cam boot, whether you're doing a diabetic foot ulcer, and you're taking out the pieces to offload, the contralateral foot is especially important to not only even up and level, but neutralize the deformities, because you could actually be putting more pressure on that side as opposed to the side that you're just treating. So I was able to get myself almost even, but I can't control for the weight. So the cam boot side, the cam boot weighs a significant amount, so that's why it'll never be 1-to-1 and making right and left limbs even using a cam boot, because unless you add more weight to the unaffected side, it's just pretty difficult. So it really did decrease all my forefoot pressure. I didn't have any waveforms there. And then my left side, which had my orthotic, and the leveler was the best, and I had a good double humped camel, as you would call it. But I couldn't get the heel time more narrow than that, and that's I attributed likely due to the weight of the cam boot. So this is what my barefoot was before that, and this is what it was after. So the cam boot really, and I had nothing on the right side, but just the cam boot, it really did significantly reduce my forefoot peak pressures. So I just definitely want you guys to understand and have that as a takeaway, that if you are going to do a cam boot, you do have to look at the contralateral limb as well. And this last article, it really shows the value that if you have distal amputations, you really need a full-length shoe, total contact custom foot orthoses, and it does best with a 4-foot rocker. So ideally for my patient, that's really what I wanted. So summary, you need to even up the contralateral limb, because the limb length discrepancy has many consequences. I actually know someone personally who needed back surgery after wearing a cam boot without a leveler on the contralateral side. The contralateral limb needs to be mechanically controlling via orthoses to not increase pressure on that side, but I don't know of a way to narrow that timing symmetrically, because the cam boot does weigh a lot. So although they can measure the same via the even up, they'll still function asymmetrically, which could torque the planted limb. So thank you. I do a TikTok where I critique people's gait, and I do that on my Instagram account as well, if you're interested in learning more.